Good morning, all. Welcome to this webinar from the Whitehouse Consultancy about reforms to the NHS entitled Medicine and Moonshots. How will the government change the NHS? We are very pleased to introduce Baroness Finlay, who's going to be chairing this session, and I now hand over to her.
Thank you so much, and thank you all for joining us this morning for this webinar. There have been multiple reports of a number 10 task force on NHS reforms, and as we all know, the Health Secretary, Matt Hancock's speech on the future of healthcare last week raised some questions. So we've assembled an accomplished panel of speakers to discuss the potential direction and timetable of likely reforms to the NHS. I'm delighted to be joined by former Shadow Health Spokesperson and Deputy Leader of the Lords, Philip Lord Hunt of King's Heath, by the Founder and Chief Executive of Virgin Care, Dr. Vivienne McVey, the Chief Executive of the Independent Healthcare Providers Network, David Hare, and the Chair of the Whitehouse Consultancy, the Urology Trade Association, and the Lift Council, that's Chris Whitehouse. And of course, it's also his consultancy that are hosting this. We have some prepared questions, and I'm going to ask the panel to work through those first of all, but we really do want to hear from you. So please put your questions as we go in the chat function. That will be monitored by Chris Hodder, and I will have those questions coming through to me, and I'm also going to be monitoring that. I'm going to ask you not to try to use the raised hand function or anything, only use the chat function to put your questions in. And I'm sorry, we're not going to have time to go to each of you in turn for you to ask them yourselves individually. But if you want to put your name on your question, then I'm delighted to credit you with a question. Obviously, if you want to be anonymous, please let us know. So I'll ask you all to remain mute, please, throughout, other than, of course, as speakers. Can I have the next slide, please? So the first question that we've got for the panel is, where is the balance between local and national accountability, and how should this work in practice? So I think, if I may, I will go to Phil Hunt first, Lord Hunt of King's Heath.
Well, Laura, on the face of it, it's a simple question, but it's one which people running the NHS and politicians have struggled to get to a satisfactory solution, basically ever since the NHS was started in 1948. I mean, its founder, Bevan, made this rather, I thought, illustrative remark by saying that basically he ruled out in the post-war Labour cabinet that discussed this, ruled out local government running the health service, because he thought it would be a patchy second-rate service, and he wanted a national service where things would be pretty equal throughout the country. But he then said he wanted to devolve decision-making down as much as possible to local level, local committees. And in essence, you know, that structure remains, and we are still struggling to work out how best to run basically a national service through 300 or 400 different organizations. I don't think it's solvable. The fact we've had so many restructurings, 20 or 30 since 1948, suggests that there is no easy answer. And maybe we just have to be honest about this. If we want a national service where basically it's pretty equal, you get the NHS wherever you are, inevitably the big decisions are going to be made nationally. If we want to maybe learn some of the lessons of COVID-19 and move to a much more devolved decision-making process, we have to accept that actually the role for the national bodies becomes much less. And I don't think this, unfortunately, politicians say you can have both. I don't think you can.
Thank you very much, Phil, and thank you for putting it in a historic context. I think that's incredibly helpful. Vivienne. over to you.
Yes, thank you, Lord Hunt. So I suppose I was going to say a similar thing in that I think I don't think there's no easy answer to this. I guess I've worked half my life in the NHS as a doctor and now half of it providing services in the community, all publicly funded services. And I would have to say that at one end of the spectrum, you know, for a service that treats you when you are ill, you want national standards, you want national investment. We want to have we have a world-class national health service if you are seriously ill. At the other end of the spectrum, what I've observed working both as a GP and now providing services in the community is that I think there needs to be actually more local accountability around how those services are provided. So I would be a proponent of more local accountability for services which are provided in communities. But I think overall what I'd prefer to see is just more accountability. I think, you know, we're entering a period where we're going to enter the biggest recession probably in our lifetime, where every penny of money that's spent on services needs to be carefully looked at and accounted for. And I think I do think we need to strengthen both national and local accountability so that we know what we're spending our money on.
Thank you. David?
Yes, at the risk of sort of agreeing with what's been said, I think it is an insoluble challenge, the distinction between national accountability and local accountability, and in a service of 1.3, 1.4 million people with more organisations than I think anybody, even if they've worked in the NHS for decades, can sort of name check. You will always have that tension. I think at the heart of it, of course, is in a system and a service that is so beloved by the British public that the Secretary of State will always be seen as ultimately accountable for whatever goes on, and I'm sure we'll come back to the Lansley reforms and the 2012 Act and so on. But one of the curious elements of those proposals was a sort of decoupling of those 2 points, and ultimately just purely for raw politics, the Secretary of State will be accountable, and therefore there will be a tendency towards centralisation. I think when you then look at how that flows down, Jim Mackey, the Chief Exec of Northumbria NHSFT, puts it best when he said, the challenge for me in this area is to ensure that we remain in control and accountable of the service here, and to avoid the grey suits in London or the regional team taking over, and it's our job to make sure that we're delivering excellent care, because in a system that does have that political national sort of accountability, it isn't long before that level of intrusion comes into local systems. So I think we do have to be honest about those trade-offs and tensions. We'll never get that balance right. We're running out of numbers for the amount of planning footprints that we could have. We've done nearly all of them now, but I think we just have to be honest with those tensions and actually ask a different question, which is how can we empower the people locally to do the best possible job so that those tensions are manifestly less in as many localities as possible.
Thank you. Chris?
Yeah, just briefly to comment on this one, because I think it's a myth that there's local accountability within the NHS, and indeed not much in social care either. There's almost none. And I think, therefore, if you want decision making locally, I think you need to look at how you introduce that accountability to the local people, as opposed to through statistics to the national agencies. Paul Corrigan grappled with this under Blair's government, and his solutions was the Hospital Foundation Trust and engaging the community that way. I think it would be fair to say it doesn't work. I think the other end of the scale, and all three other speakers have put their fingers on it, the fact is, de facto, the Secretary of State will be held politically accountable for these decisions. And therefore, the outcome of this process that we are going to go through, however open or closed the process it is that Matt Hancock is going to have to take back control and power of some of the decisions for which he's being held accountable, when in reality, they're not ones he had that say in the first place. So I think we will see big changes. It will be dressed up as powerful local decision making. Matt Hancock's already started doing that at his press briefings, but in reality, he has to take back control nationally. And I would personally like to see, as I come from a local government background as well, more accountability at local level for the NHS. But ask me how you do that, I honestly don't know.
Thank you. And we're going to move straight on to the next question, which is which NHS and Department of Health Social Care units are ripe for taking down and which might become unintended victims of change. I'm going to go to the speakers in the same order as before. So Phil.
I'm very sceptical about structural change because basically I've suffered through too many, and frankly as a minister I took too many bills through Parliament restructuring, so I don't come at this with a great deal of enthusiasm. I want to just come back perhaps to something Chris said earlier, that the crux of the issue is the money for the NHS is raised entirely centrally, or 99% of it. It's funded through Parliament, it's voted by Parliament, ministers account to it. If we have a structure like that, it's inevitable that the Secretary of State, the DHSC, will, whatever the vagaries of the Lansley model, want to take back control. And so for me, I don't think it makes sense to have a separate agency like NHS England. It has no real independence. I mean, it might even in statute pretend to be independent, but the reality is all its authority comes from the mandate given to it by ministers. And I think we should really at the centre, I would forget all the fiction of having these different agencies, NHS Improvement, Health Education in England, and bring them all together. At the moment, the national architecture is very, very confusing. And we've seen it in COVID-19. Clearly, part of the patchy response is because so many different people have had their pies in the pudding, and it simply lacks hearing. At local level, I think the key thing is taking STPs and giving them statutory basis, because they look to me to be like a reasonable planning and funding unit at local level. And I think that I wouldn't do much else, actually. I mean, I think CCTs can be folded into them. And then I would actually leave Foundation Trust roughly where they are, because I think if we can avoid a lot of restructuring around the people who actually provide the services, we can actually lessen the sort of 2 to 3 year hiatus you usually get from restructuring. So I would go for probably sort out the centre, a minimalist change at local level, but give us a planning and funding body that is big enough to be able to sort of plan and commission effectively.
Thank you. Vivienne.
Yes, so thank you, thank you, Lord Hunt. So I think I'll sort of maybe pick up where you finished, because I agree with your assessment of what should happen nationally. I think for me, looking at what happened during COVID-19, which we were very involved in because all of our services are in the community, I think there needs to be a more national thought about where accountability for the public's health in general sits, and who has accountability for that. And I think, as we said in an earlier answer, I think it's a lot less clear when you get when you get very locally. I certainly have a view that I think more accountability for that should be given to local government, having had the experience of being commissioned by both the NHS and local authorities in the community. I think in general, local authorities do a better job there. But I think for me, it's very much about seeing how the two work together in the community. And I think we have to give responsibility though for public health to one organisation or another. At the moment, it kind of sits across both. And I think we saw that play out in COVID, that it wasn't absolutely clear who was manning the public health response. And I think we've seen certainly then when, say in the Leicester lockdown, actually when the Leicester local authority has had responsibility for managing the public's health, then that's probably been more successful. So I think it's about having clarity. I think we will see, some organisations which are subscale, such as CCGs, will merge and the smaller ones will disappear. And I'd like to see what happens with Public Health England.
Thank you. Good question there. David Hare.
So of course this question presupposes that anyone anywhere in the country that knows has a list of all the NHS and DHSC units that actually exist, and I suspect they probably don't, and therefore that's right at the heart of the challenge. I'm always encountering new ones and questioning what some of them do. I think to echo Lord Hunt's point, I think that the danger of huge structural reform is huge. I'm told the average life cycle of a planning footprint, whether it be a PCT or now CCGs and health authorities and so on, before that is about 5 years. And so CCGs have probably already passed their sell-by date in that sense. But then when you step back and think about a full-scale national reorganisation of that architecture, of course you've got 2 years where everyone's applying for their jobs again, everybody is totally distracted, and actually the opportunity cost is dramatic. So what you, I think, just have to focus on, we all acknowledge that it is imperfect, but you have to focus, I think, not on blowing up organisations and creating new ones and lots of flip charts that look very nice, but then don't flow, just distract everybody. You have to try and make the best of it, and I think you can make some small adjustments locally, whether it be STPs or ICSs, and I sometimes forget the difference between the two. I do think there needs to be a statutory component for those organisations. I think we spoke earlier about accountability. It has to be that locally it's clear who is in charge, who is making the decisions, and whilst I think ICSs and STPs have been able to make some progress by the collegiate nature of their structures, actually you do ultimately need, there are no statutes of committees, and you do ultimately need somebody to be able to take that decision. Nationally, I do think there's been a bit of a journey towards sort of defragmenting some of the architecture. I think, it's still the case in law. There's a commissioning board, monitor, and the Trust Development Authority. None of them are in existence as far as the public is concerned in terms of names. So, try and bring some more of that together, and then just try and have a chain of command from national through regional to local that is as intelligible as you can make it within the current structure. Because frankly, we just don't have this pandemic is going to be with us for a period of time. We just don't have the luxury of wasting 2 years on full-blown structural change. So, I would look at it slightly differently.
Thank you. And Chris?
Yeah, I've got a few very brief observations just to throw into the mix. I think one of the lessons of the Lansley reform was that disruption of itself is a bad thing. It might lead long-term to something better, but the loss of organisational memory, the loss of continuity, the loss of expertise, we're still actually living the legacy of that within the Lansley reform. The second thing that I would say, to pick up on what Vivienne was saying, is I think locally public health has had a good pandemic.
Yeah.
Local services configured by people who know the strengths and weakness of their own organisations and needs of their community, I think have delivered well. I think what it's also taught us is that the NHS, in partnership with the private sector, is when it's best. Because what the private sector can deliver is expertise. It can deliver organisational memory, and it can deliver capacity and evolution at pace. And I think that's one of the main messages from the pandemic, that, for example, every private sector hospital just about, David and his team bring into play to provide NHS treatment in order to free up the capacity within the NHS. Smoothly, quietly, calmly delivered. And that's what the private sector, when it sees itself as a partner, the NHS can deliver. So, like David, I suppose I'm a bit sceptical about massive reform, because I think the disruption is not what we need right now. There will be changes in power and accountability in decision making, but the private sector, I think, will evolve to serve as a friend and partner of whatever the new structure is. Because if it doesn't thrive. That's the nature of the private sector.
Thank you. And you've all, one way or another, mentioned COVID, which takes us very neatly on to our next question, because it is which emergency measures put in place by COVID-19 are likely to be permanent. And I think it's really something worth considering, because actually there have been phenomenal changes. Just for the sake of change and moving everybody round, Phil, I'm going to move you lower down the queue, if I may. And I'm going to start off with Vivienne and then go to David and Chris.
Oh, thank you. Well, I think I'm only going to talk about actually one of the sort of 5 main emergency measures, which was about easing the burden on frontline staff, and which of those things do I think will become permanent. So this was the sort of push to remove admin tasks from frontline staff, allow key workers to work remotely, and to prioritise care for those with the most pressing needs. So those were the sort of goals, and a lot of emergency measures were put in place. So I think, which do I think will become permanent? I think certainly we will see a lot more remote working, clearly, of key workers. I think there were lots of great things introduced in terms of things like doing remote palliative care, which actually gave people more support. A lot of services for children were moved online, and that had actually, we found that health visitors were reaching more children doing that. But all of that has to be done carefully, because clearly there are unintended consequences, and the ones who suffer the unintended consequences are the most vulnerable. So they're the people that are not online, they're not. So whilst you might have the key workers working remotely, you may not have the most vulnerable in society. So the frail elderly and the families who are vulnerable being accessible that way. So we absolutely, in the big push towards remote working, which sort of makes life better for everybody, we have to be careful about safeguarding. I think removal of administration was fantastic, I have to say, and I think it makes me really question the value of a lot of commissioning that has been happening inside the NHS. I think it will make us move more quickly towards commissioning for outcomes, which is what more local authorities do, because this sort of intense contract management, I don't think achieves what it sets out to achieve. And then I suppose for those with most pressing, I think what was remarkable was the rapid discharge of the frail elderly from hospitals, not always done well, as we know, but across the country there are great examples of the NHS and local authorities working together to actually discharge people quickly and to support them in their own homes after that. So I would like to see that continue, but it has to be done safely, and clearly I hope we never ever see COVID positive patients being discharged to care homes again. That was a scandal.
Thank you, David.
Yeah, so 2 I would draw on, and then I guess one area of concern that's a link point. So the 2 I draw on, and it's linked to Viv's point about sort of remote working and so on. But I think the NHS long-term plan had a target of 30% of outpatient appointments to be done virtually by 2022. Well, we smashed that within about 48 hours of the COVID crisis. So I think certainly if I talk to independent sector members within an IHPN, they're doing 80-90% of outpatient consults and follow-ups by virtual means, and I think that has been really, really welcome. I think there's a saving that you can make on that, but actually patients really like it. You avoid the need to travel into a hospital facility or other healthcare site. So I think that will stick, and I think we should welcome that. I think the other shift that we will, again, was sort of has been spoken about for a long time, and it happened in some areas but will now be fast tracked, is this distinction between hot and cold sites. And by that I mean those sites that are taking emergency patients probably will be areas that take COVID patients where there are further hospitalizations, and keeping sites, particularly for immunosuppressed patients, cancer patients, and routine operations separate. Now, it doesn't need to be separate organizations, but trying to keep those pathways separate. COVID brings that into sharp relief when you look at the infection prevention and control guidance, and we have to make that work now, but frankly, there is a logic to it more broadly anyway. So I think those two things will stick. Viv mentioned social care. I think one of the things that is absolutely apparent from the last few months is that we simply did not have a response architecture that was going to be able to protect social care. And my one hope in terms of lasting legacies of the COVID-19 period is that we do not continue to duck the sort of existential issue of our age, which is reform of social care. Our members are not directly involved in that, but equally are affected by it to a degree. But simply speaking as a citizen, we absolutely have to get to grips with that and cannot allow what's gone the last few months to go unaddressed in terms of the legacy effects.
Chris.
Yeah, I agree with David on that point. Social care has been a national scandal for decades and it needs fixing. The other thing, though, that I would like to see retained is an overall umbrella concept of flexibility. I think we've seen breaking down of silos at local level in different ways, in different areas, but people who know their services, its strengths and weaknesses, adapt to them. I certainly agree about teleconferencing. GPs were, really adamant to try and keep the mobile app GPs out of their patches. They've done absolutely fantastically during this pandemic, and I hope that will be a long-term legacy. But I would like to see a legacy being empowering the local health and social care communities and economies, empowering them more to come up with imaginative reconfigurations that meet their local needs. Civil servants in Whitehall or wherever they're based now, Richmond House, Skipton House, and Elephant and Castle, wherever they're based in London, they shouldn't be meddling with local decisions about how a service should be delivered. They should be measuring the outputs and the outcomes. That's what matters most to real patients in real life. So I hope that is a legacy.
Thank you. Phil.
I think we've just dropped off the call, I'm afraid.
Have we lost Philip?
I think so. I'll wait for him.
Okay, so let's move on to our third question and let's hope Philip can join us. Sorry. So really that kind of links to many of the answers already, which is what should digital transformation focus on first? And we've heard about a lot of what you might call relatively simple in today's technology use of digital. So perhaps, David, you'd like to start with that one.
No, happy to. I suppose the obvious answer is the patient, isn't it? But it sort of needs saying because quite often in healthcare, we design digital sort of digital mechanisms and it all looks very exciting, but actually it either costs a fortune, so it doesn't really help the taxpayer, or doesn't work, which doesn't really help the patient. So, I think you kind of got to start from the basics. And actually, funnily enough, and I know Viv and Virgin have done a lot of work in these sort of areas over many years, and I'm sure Viv will talk better than me about what they've done. But it's often the simplest changes that work best, funnily enough, in terms of digital transformation. So, I'll give you one example. From one of the provider members in our network. They introduced a very simple app that allowed you to say whether or not you were running late for your appointment or your procedure, and it reduced DNA rates, do not attend rates, by 90%, because what they'd identified was that people simply didn't want to be late for an appointment, late for a procedure, and then simply not turn up, and that was causing all manner of problems for the provider. But if you can create a very quick and easy way for them to say, yeah, I'm running 15 minutes late, half an hour late, traffic around the school or whatever it may be, they can then reschedule. You can still get seen. You reduce DNA rates and reduce complexity. And it's not an all singing, all dancing, it will be on the front page of newspapers type solution, but it's a material sort of improvement in the experience for for patients. I think the shift towards sort of video consults and so on has another material effect. A member of ours was talking recently to me about the extent to which in general practice and primary care they're now able to support patients do more for themselves in areas like wound care. So rather than having to come in and have to have it redressed every week or however regularly you need to do it, we can support you to do that, and then we can be available if needs be to make that easier. So I think there is a danger with this debate that we all look for the kind of really exciting big national projects, the electronic patient record, which of course we need to do, but equally actually a bit of a focus on some of the simple solutions that make patients' lives easier is also something that we must not forget.
Thank you. Vivienne.
You're mute.
Vivienne, would you like to unmute and come in?
Apologies.
Thank you.
Can you hear me now? Yes. So I would agree with David. So yes, we've used tried to introduce digital for many years now in different well, in community services, and it's the simplest changes which make the biggest difference. And digital isn't the end goal. I guess that's the important thing. It's about focusing on what you want to achieve with for the workforce and for the service users, the people that use the service, and then designing the technology around that rather than the other way around. So it's about working on the outcome and then using digital to achieve that. But I suppose and also, as I said before, always having safeguards built in for the vulnerable and those that don't have access to it. But what we found is, the simple introduction of good mobile technology to community nurses has definitely, every time we've introduced it, increased productivity of nurses considerably, and also increased patient-facing time. That's the important thing. So actually it reduces the amount of time they spend traveling, it reduces the amount of time they spend on admin, and that has to be a great thing. If they then have longer to spend with the frail elderly, that's the important thing. And just simple things like e-rostering, which is now, we're hoping to, I think the whole country is hoping to get e-rostering into community services. It sounds really simple. It's hard to do because you have a very varied workforce who are working very different work patterns, but once you do it, it has great benefit for everybody. And this allows people that flexibility. So I think, yes, it's the simple things. And I think integrated record, I think given the way that we're moving to greater integration of organisations, I think that can be solved, but on a local basis. And I think it needs, it needs vision from local commissioners to decide that they're going to support local organisations to invest in it. I think trying to impose it from the centre will always be doomed to failure. Thank you, Chris.
Well, I think I have to say I also agree with David, and for those of a particular age, I'm just glad he's not called Nick. But what I would say is it is about the patient experience. But I think Vivienne's put a finger on the possibility of marginalisation from those who aren't digitally empowered. And she's drawn attention to the fact that in fact some of the most vulnerable and the most at risk who might be most digitally marginalised and unable to access some of these services. I actually think it will make economic and healthcare outcome focused sense to ensure that these particularly vulnerable people are connected digitally. And if that means that GPs and community nurses have to look at a way of supplying them with access to the digital world, i.e. whether that's a phone or a camera and a laptop, actually, even at the top end of this scale, a laptop with a camera and connection to decent broadband is an awful lot cheaper than a hospital admission for one of the more common conditions that they could contract. So actually, I think we need to think outside the box. The government did that with the most vulnerable school children. It sent them laptops. What happened to that laptop will be an interesting study. How many were ever set up? How many were sold on eBay? I will be interested to see that result. But for this particular group of patients, I think it makes every good sense to have them brought into the digital world as soon and as effectively as possible, even if that means a short-term hit to the public purse.
Thank you. And I think we still don't have Phil back, which is really quite a great loss for us. So I'm going to go on to the next question that we've got, which is what needs to be protected from the Lansley reforms and what other changes need to be made. And I think that really sums up somewhat some of the things that have already been raised. So rather than repeat points already made, I'd be grateful if you could think about other areas. And David, possibly we could start with you.
Thank you. I mean, obviously, I guess the Lansley reforms were, so and in the dim and distant past, sort of seen as, I think, a very sort of difficult time for the health debate. I mean, inevitably, with any set of changes of that scale, and they're, it's an easier job to list the things we keep probably than things we should not keep. There will be things that are beneficial. I think there was an opportunity through the introduction of things like Health Watch to increase the voice of the patient in local system design. Question whether that's happened routinely, but I think that emphasis that was brought through that debate on the patient voice in the planning and commissioning process, I think was quite powerful. I do think that we have to retain, and clearly this preceded Lansley as well, but we have to retain that independent commissioner capability in a local system that is separate from the provider base, to be able to act as a sort of neutral party, as it were, on behalf of the patient in allocating funding in a local system. Whether you go back to the debates then, and whether that was the right or wrong way of doing it, you can argue probably endlessly. Equally, I do worry that blurring of the commissioner provider split that we're seeing in a number of areas at the moment, that risks lack of clarity over governance. It risks providers becoming sort of making decisions really that work in their best interest rather than necessarily the wider system. I think it's really important that we protect that distinction between those two. And frankly, if the commissioning footprint can be larger, if it's on a sort of ICS SDP footprint, then that probably will help, because it gives that entity more clout in being able to argue the case with the providers in that patch. We need to retain that, but equally I think there's a lot that we could probably not necessarily reverse from, but learn the lessons of the last few years, put it in a sort of post-COVID context and say, actually, we probably just need much more clarity in terms of the chain of command from top, middle to bottom, and to defragment some of the architecture that was thrown up by that act.
Thank you. Vivienne.
Well, interesting. I was going to say almost word for word what David's just said, the 3 points. So I won't repeat all of that. I think there's one other area that I might touch on, which is just what the role of GPs in particular were viewed as being during the Lansley reforms. So I was a GP and I've lived through the Lansley reforms. I think the thing that was good about it was that we have empowered a generation of GP leaders who I think we should continue to develop, who are able, who have a voice as an advocate of the patient, and who understand how primary care work. And I think that voice was missing in the NHS as a whole. However, I think we lost the talent of many good frontline clinicians working in committees which they were neither trained for and which were subscale. So I would both want to retain the sort of leadership of primary care that the Lansley reforms led to, but actually I don't want them tied up in small subscale commissioning organisations. That is not their skill. I think I would love to see much more involvement of primary care with working with local authorities and their third sector organisations and their community services. I hope that the primary care networks will lead to that, but the jury's still out for me on that.
Right, and Chris.
Well, I actually think the Lansley reforms as such are lost now in the mists of time. It doesn't matter who introduced what about our NHS, we've got what we've got. The fact is, what are the real strengths of it post-COVID? And I think the role, as Vivienne was saying, of primary care in this, driving local service reconfiguration, engaging with public health, engaging with social care, engaging with children's services. I think this is absolutely hugely important. And I think we need a joining together for a local economy and local community to focus on what it wants to achieve. Because whether you're dealing, for example, with a young child with a learning challenge like cerebral palsy, for example, or whether you're dealing with an older patient who's at the beginning of a urology condition that will be with them possibly for the rest of their life, whichever it is at the end of that scale, the earlier you identify it, intervene with it, and have an impact, then the more you're going to improve the quality of life of that individual patient by slowing down any progression, possibly by curing. And at the same time, you're going to massively reduce the burden on the taxpayer and the local service provider as well. So I'm not so bothered who introduced which reform in the past, and I see Philip's joined us again now.
Yeah, exactly.
So I'll end there.
I'm so glad to see it looks as if we've got Philip back again. And so, Phil, because we don't want to lose you, I'm going to let you have the floor to say whatever you want to the questions which you missed out on, which I think were, apart from what needs to be protected from the Lansley reforms and what other changes need to be made, we also had which parts of digital transformation should be kept and are likely to become permanent. And also, I think what we've learnt from COVID and which of those changes should become permanent. So, Phil, you have the floor, and it's great to have you back.
Thank you. Just on COVID-19, I mean, the two key things I think I learned is, first of all, that when you let people have a head, and these are both in terms of people running local health service, but also people at the front line, they really rise to the challenge. And we've seen so many fantastic examples of innovation. Somehow we need to capture that for the future. I heard, what Vivienne and David were saying, and I agree with that. We've got to remember there are some people for whom there is a danger that they get forgotten, and we will need, in order to make sure they're not discriminated against, to have opportunities for people who are not okay with digital, don't want to use it, or do want to have face-to-face consultations. We are going to have to allow for that. On Lansley, I didn't think much of the Lansley reforms, but equally, the last thing we want is to...
We seem to have lost Phil again. What a pity. Okay, I will, while we hope to get Phil back again, and I'm just going to ask the team centrally to see if they can see what's happened. We've lost him. I know he's in an area of poor signal, and gosh, we are witnessing that, aren't we? We've had some questions come through in the chat, and we've, in fact, Laura McCarthy asked, considering the upheaval of structural change and the time it takes to implement, is it ever worth working to improve the structures that we've got in place rather than contemplate structural change yet again? And therefore, should we abandon even trying to do that? And Neil Ayling has agreed with comments made about local authorities knowing their community well. He works in social care in North Wales, and he would like to know if there's a way of making sure that services are more responsive as the local authority services tend to be, whether the NHS services could be more responsive. So I will go over to you on those, but I also like to add in one of my own, which is relating to 111. And none of you have spoken about 111, but taking evidence from long COVID survivors, I do worry that the algorithms used on 111 may not have always served people as well as they should. And some of the simple questions, which I think have now been changed, such as, are your lips blue, are completely inappropriate for people of the BAME community, where you can't see if their lips are blue. So, and the other problem has been some, I've heard anecdotally say that because they could answer a question, they were deemed to be okay, when actually their answer was the only words they could get out. They were so severely breathless. And with all of that, actually, does 111 do what it should, or should we have had more going out, pulse oximeters and whatever, out into the community to check on people physically more than happened? So can I go over with that question, first of all, to Vivienne, who's been out there in the community, and those other very community-focused ones. Just before you answer, Vivienne, I just want to see if Phil has been able to rejoin us. I don't think he has. No, let's go to you, Vivienne. Thank you.
Thank you. So, sorry, do you want me just to speak about 111 or do all three questions?
No, take all three together, because if we can get Phil back, it would be great if we can hear from him in a block.
Yeah, okay. So in terms of upheaval of structural change, I think you've heard it from most of the panel that actually generally structural change is not the right solution when you're trying to improve services at pace, and that it rarely achieves the change, or really structural change alone rarely achieves the improvements it sets out to. I think it's clear that what we do need is greater definition of who has responsibility for what and greater accountability, but you don't necessarily need structural change for that. And a lot of what was achieved during COVID was achieved because of good personal relationships between leaders of organisations. And again, you don't need structural change. So it's perfectly possible for organisations to work well and move mountains as they did during COVID, if you have the right leadership in place, which has the mandate to get on with it. So that would be my comment on that. I agree. I think my experience sitting in both camps of the NHS and local authorities is that local authorities know their communities much better in general than the sort of local NHS does. I think one thing we did see during the Lansley reforms was obviously public health was moved, the responsibility was moved to local authorities, and actually we have seen some really good results, and particularly we're starting to see some really great outcomes of children's services occurring as a result of that move. So I think there is precedence for moving more what was traditional NHS responsibility to local authorities, and I would like to see more of that happen. 111, I can't disagree. I think the algorithms were not set up, but when we'd never seen a virus like this before. I think the learning from that is clearly that there needed to be a greater response, quicker response to change things when it wasn't working. And I think it does say something about the kind of communication flows within the NHS are not always what we would want them to be, and we know that. I think also, though, I think we need to be very cautious, and it's back to the point that Lord Hunt was making before he was cut off about making single digital routes the only way of access into the system, because it really does potentially discriminate against people who are more vulnerable for whatever reason. And I think I was particularly perturbed by the fact that many A&Es shut down. You couldn't walk into GPs, and there were very few avenues actually for people to get help without having to go online or phone to make an appointment. And I think certainly we need to look at that for the second surge. We cannot design a system that needs everybody to have an appointment, because that, before they can be seen in an emergency situation, because that definitely discriminates against the vulnerable. I saw that in my own family, with my niece, who's a student. She didn't know how to get help, and she was very poorly with COVID. And if she hadn't been able to walk into a hot site, I don't think she would have got appropriate help. So we need to preserve that.
Thank you. And actually that walking into hot site also, of course, links to the problems that A&E had before, which were that they were absolutely swamped, and we can't have them become sites again of nosocomial infection, of cross-spreading. So we need to really rethink the way that those emergency services can be accessed to keep things diverted to other services that should be diverted to other services. David, let's go to you.
Yeah, so I think on the 111 point, I agree with what Viv has said there. I know, speaking to 111 providers in March in particular, the sheer volume of calls that they were getting was astronomical. 100 times increases on what they would normally be getting, also from a very worried population as well. And I think that they would be the first to acknowledge that the algorithms and the way in which it worked was probably having to learn sort of every day, and when the wash up comes will not have been right. I'm sure of that. But I think we have to acknowledge the sheer pressure on those providers. I think looking ahead with 111, there's discussion about using 111 as a route into A&E. I agree with Viv. I worry if we end up really narrowing the patient's access to sites that they can walk into, that actually you really artificially restrict patients' ability to be able to access healthcare services. And of course, I don't agree with this, but the argument has been put by many in recent weeks that in effect we now have a national COVID service, not a national health service, because a lot of other procedures have been put on hold. I don't think that's right, but we must make sure that those services are accessible and that people can find multiple ways in. I was quite a big fan of walk-in centres and other direct access services that largely sort of ceased, and I think we should probably be looking to expand the accessibility of healthcare rather than restrict it. I think on Laura's point around, is it worth taking the time to work with the existing structure, I think I probably dealt with that earlier. Overwhelming answer, yes, because of the sheer distraction effect of large scale reform. And in terms of local authorities and NHS commissioning, I've seen good and bad examples of both. I think actually the challenge is to make sure that we're clearly defining what good commissioning looks like, commissioning for outcomes wherever we possibly can, and ensuring that local authorities and whoever the commissioning organisation is, but CCGs over recent years, are working really well together. And I know that's something that in her role as Chief Executive of NHS Clinical Commissioners, Julie Wood did really well, working with local government to say, okay, how can we do this on a joint basis, so we're not just doing it commissioning in silos.
Thank you. Chris.
Yes, I agree with Laura. She'll have understood from my earlier remarks that wholesale reorganisation of the NHS would be more than a distraction. It would lose organisational memory. A lot of the lessons, ironically, that we've learned from COVID would be lost if we have too much change. So I'd like to see a bit of tinkering and more empowerment. In response to Neil Ayling's case, I think he's from Flintshire, a Chief Social Services Officer, or something of that nature. Agree entirely. You'll see from what I said earlier, I think a good local authority, when it's being imaginative and challenging of itself, can deliver stuff on the ground that is frankly revolutionary. When they get the right end of the stick, identify, intervene, and impact as soon as possible. And in nowhere could that be more important than children's social services. You keep one child out of a children's home for a few years, and you've got the budget to employ a whole new social worker. So, I mean, it's really important. The 111, sorry, I'm going to duck that. It's a clinical and data processing question. I agree, it's fundamentally important. All I would say is it's a job of review that must be done to make sure that service has the capacity, but that capacity is scalable in a very short term, and it has the right algorithm on what they should be, not my bailiwick, as it were. On access, though, yes, I've advocated digital access on this call, and I'm happy to continue to do so, but that's not exclusive to other forms. We need diversity of access. One of the things the digital environment has told us is people choose to access content, that's to say services, in a variety of different ways, even within the digital environment. And I think we should diversify the way they can do that. It shouldn't always have to be a GP Babylon and app or on your iPhone. There should be other ways of accessing these services digitally. It may be through your TV and your remote control, if it's internet enabled for Netflix and that sort of thing. But I also agree very strongly that there needs to be walk in, crawl in, be taken in dad's car and pushed in access to hot accident and emergency. And I think the two go together, because the more people we can keep out of accident and emergency who don't need to be there in the first place, the better. I saw a fantastic study, I must look up the reference at some point, done not long ago, where they found that a huge percentage, before COVID, of patients presenting an accident and emergency in one major district general hospital didn't actually need to be there, but they were making up something like 35% of the attendance there, so much so that they found that if they employed a couple of people to pop round and have a coffee with them once a month, that's all they actually wanted. So I think we need to be diverse about the services we provide and the routes of access to those services. And I wouldn't be preclusive or prescriptive about what those should be.
Great, thank you. We're really right up against the clock now. Philip, unfortunately, hasn't joined us again. So I'm just going to leave you with a couple of thoughts as the audience, particularly because I know we've got some parliamentarians on here, and obviously things are going to be pretty important from September for all of them. And one of the questions that came in we haven't had time to address is whether reforms are necessary to ensure our healthcare system can deal with the pressures of procuring medicines and medical devices. Very relevant with a bill that's going to come towards Parliament. And I also want to leave you with a thought of whether actually we have a culture in this country of trying to defer doing things too much. So we're too slow to do some simple investigations, or too slow to undertake a procedure, and the result is that actually we leave somebody with a worsening condition and we stack up problems for the future, and whether we need to make the whole system more rapidly responsive and more rapidly testing. And some parts of the world have services that are more rapidly testing, do procedures more readily, and perhaps we can look just across the water to our European colleagues and think about the ability of some people. And anecdotally, I'll leave you with a thought of an aunt of mine who in her 90s had valve surgery on her heart. It transformed her last years. I fear that if she'd been in this country, nobody would have touched her, but she did really well. And that was it, that was in France. So I think, you know, there are lessons to be learned from all over the world. Thank you so much, everybody, for joining us. And I hope that those of you who've come in and listened in have enjoyed it. And particular thanks to the panel for their very, very thoughtful responses. And I wish you all well and to stay safe and COVID-free. Thank you. Bye.
Thank you.
Thank you.